This is Andrea Kane, and I'm here with you for HIT 120 Pharmacology. We are now on week 13. Hard to believe. Just a few weeks left in the semester. We're working on miscellaneous drugs this week and next week. But this week we're going to focus on chapters 40, 41, 44, and 45. If you want to follow along in your book, I'll be starting on page 205 here in just a second. Wanted to remind you that our unit objectives for this week continue to be 9.3.1, 9.3.2, 9.4.1, and 9.4.2. This is going to be a fairly quick lecture. In fact, I'm hoping to keep it right around 20 minutes because although we have quite a bit of material, I think it can be condensed down fairly easily. So I hope that you'll enjoy a shorter lecture video. So we'll go from there. All right. Let's see. Computer's wanting to go slow this morning. All right, so what are we going to talk about? We're going to talk about histamine and antihistamines. We're going to talk about respiratory drugs, immunosuppressives, and drugs used in osteoporosis. So let's start talking about allergies. It's estimated that allergies are the sixth leading cause of chronic illness in the United States, and prevalence is on the rise. Allergens are substances that trigger allergic reactions. They exist everywhere and in hundreds of varieties. Men and women of all ages suffer from allergies. It can be environmental, pollen, pet, mold, dust mite. It can be insect related, whether that's a bite or whether it's exposure to insects. It can be a drug allergy. We've talked about having reactions to certain antibiotics. And then there can be food allergies. Those are very common. Lots of people have allergies to peanuts or other kinds of nuts, tree nuts. People can have dairy allergies. They can have wheat allergies, corn allergies, soy allergies, fish, shellfish, all those types of things. The reason I put this next slide in is because if you look in the center, you see histamine here in the center, right here. There are actually four types of histamine: H1, H2, H3, H4. We are only going to talk about H1 and H2. So if you are really curious, I'd encourage you to go out and do some research about H3 and H4 if those are areas of interest for you. But what we're going to talk about is H1 and H2. So make sure that you're familiar with those. Make sure that you know that H1 is the traditional allergic reaction that people typically have. I just realized my volume might have been too low, and I apologize for that. Hopefully you were able to hear at the beginning of this. But yeah, so H1 is the allergic reaction that typically we associate with exposure to an allergen. It's the runny nose, it's the watery eyes, it's the sneezing, it's the coughing, it might even be a little bit of shortness of breath. That's a histamine 1 or H1 reaction. Then there's H2, and that goes on to involve the gastric acid in your stomach and how that's secreted. For instance, my daughter has a lot of food allergies, and we've taken her to Mayo, and they've gone through all of that with us. But her reaction to her food allergies is this H2, this histamine 2 type of reaction where she gets sick. So those are the two we're going to focus on. Those are the two that you need to be aware of. But if you're interested in H3 or H4, I'd encourage you to take a look at those. All right, so what do you need to really know about histamine? Histamine is released by mast cells, and you have mast cells throughout your body. But the ones that we're going to talk about, the H1, H2, are the histamine is released especially in the respiratory and GI tracts. That's not the only place, but that is the primary area that these mast cells release histamine. It happens when the body encounters what it considers to be an allergen, and it produces physiological responses. Now, this next piece is so important. Please, please, please star this. The severity of the response, the physiological response to when the body encounters an allergen, is dependent on the amount of histamine released. It is not dependent on the allergen. It's not dependent on how much of the allergen that's encountered. It is entirely dependent on the amount of histamine those mast cells release. So if you are a person who has these mast cells that tend to release a lot of histamine when they encounter an allergen, the severity of your physiological responses are going to be much more severe than someone whose body has mast cells that only release a little bit when they encounter an allergen. So make sure that you understand this concept. The severity of an allergic reaction or the physiological symptoms that result when the body encounters an allergen is dependent on the amount of histamine released. Not the allergen, not the type of allergen, not the amount of allergen. It all has to do with the amount of that histamine that your mast cells release. All right, so moving on. What are those physiological responses, aka also known as allergy symptoms or allergy reactions? They include decreased blood pressure, decreased, not increased, but decreased blood pressure, an increased heart rate, not decreased, but increased heart rate, constriction of bronchioles, that makes difficult breathing happen, sometimes asthma, a cough. Intestines get contracting. That can either result in constipation or diarrhea, depending on how your body responds to the histamine that's contracting the intestines. There's dilation and edema of skin capillaries. That's where you get the redness, the rash, the watery eyes, the runny nose, all of that. Those capillaries dilate and swell and get irritated, all of that. Then there are some nerves in the spinal thalamic tract that trigger itch-specific fibers. So that's where you get the itching. The skin capillaries do the rash, but the itching comes from some nerves that get triggered. And so they cause that sensation of needing to itch. And gastric acid secretion increases. So you end up with nausea, vomiting, heartburn. I'm not going to repeat it here because we already talked about the allergens that people may come across, but they're listed here to remind you to be sure and study those for the quiz. All right, so what is histamine intolerance? So we talked about histamine, but what happens when someone's body releases too much histamine and they do it on a regular basis? Those mast cells, they get that histamine going, and instead of stopping when it needs to stop, it keeps on going. So it's like having a constant allergic reaction. That's called histamine intolerance. It can be caused by drugs, medical conditions, the environment, nutritional deficiencies, diet, the GI tract releasing too much histamine, or there are situations where people lack a specific enzyme, and so the body feels to break down histamine after there's been a release. Because normally you have your histamine that gets released and the body knows to break it down. It has an enzyme whose job it is to do that. With histamine intolerance, with some people, they found that they lack that enzyme, and so the histamine doesn't get broken down, and that contributes to histamine intolerance. You have very similar symptoms as an allergy reaction, and there are lots of treatments. One is a low histamine diet. Yes, did you know that there are foods that are high in histamine? And you can look that up. I've given you some links here that you can do that with. Or you can type in histamine intolerance and go explore that. But to treat histamine intolerance or someone who's got too much histamine going on, that's where they do the low histamine diet, antihistamine medication, and then this DAO supplement is the enzyme that's lacking. So by taking that supplement, it helps people who have that enzyme lack. And for people who don't have that enzyme lack, it just simply helps them break down histamine faster and more of it to try and get back down to that normal level where the body is not in constant allergic reaction. Taking corticosteroids can help, and or avoiding drugs that are associated with histamine intolerance. There are some anti-inflammatory or pain medications that are known to have sort of a histamine intolerance result or reaction. So this is all about histamine intolerance. This diagram here shows you on the left what it's like when you get that histamine released. So on the left, those mast cells have released the histamine. The histamine are going to the histamine receptors. And by the way, you have an enormous number of cells in your body with histamine receptors. That was one of the interesting things I came across when I was researching this. And that then results in areas of allergic reaction. But on the right-hand side of the screen, you see what happens with the blue. The blue is an antihistamine, and that comes in and it blocks those receptors so that not so many get filled with histamine, and that reduces that allergic reaction. So you can see how antihistamines, how they're designed to be antagonists and blockers, where they're taking those receptors and histamine can't knock them out and take those back over. All right, so let's talk about antihistamines. As I said, these are H1 or H2 receptor antagonists or blockers. That's what we're going to talk about. Remember, H1 and H2. Those are the two major subgroups. And when you think about it, it makes sense. H1, the location of effect has to do with the respiratory system or respiratory issues. With H2, it's all the GI tract and GI issues. So when they design antihistamines, they design them to target where they wanted them to have the biggest effect. So H1 receptor antagonists and blockers, these are H1 antihistamines. These focus on the respiratory, and they try and target allergic rhinitis, allergic conjunctivitis, and hives. Within the H1 antihistamine category, you have first-generation drugs and second-generation drugs. First-generation drugs cross the blood-brain barrier and cause drowsiness. You need to know that. I'm going to say that again. First-generation H1 antihistamines cross the blood-brain barrier and cause drowsiness. But they also have the ability to be used to treat insomnia, motion sickness, and anxiety. Second generation H1 antihistamines do not cross the blood-brain barrier, so there's no drowsiness there. But on the other hand, they cannot be used to treat insomnia, motion sickness, and anxiety. So by taking away that blood-brain barrier in those second generation drugs, they take away some of the additional features they might have, but it allows people to then take those second generation antihistamines during the day and not be sleepy. Now let's move on to H2. H2 receptor antagonist blockers, or H2 antihistamines. These focus on GI issues. They are used to treat GERD, gastritis, duodenal and gastric ulcers, and nausea and vomiting. There are other conditions that can be treated with antihistamines. Interestingly enough, they include anorexia, headaches, anaphylaxis, vertigo, Parkinson's disease, and some types of bone pain. Side effects are dependent on type. And again, as we talked about, the problem with H1 first generation antihistamines is drowsiness. That's the biggest piece. And then I'm not going to go into a whole lot of detail with these, but just be aware of the side effects and maybe know the first 4 or 5 so that you're familiar with that. All right, I wanted to give you a list of first generation drugs. Some of these are probably familiar, especially when you're talking Benadryl. Phenergan is used a lot in the hospital setting for nausea and vomiting, and also for nausea and vomiting quite a bit, but it can be used for other things. And Dramamine. Anyone ever had motion sickness or been around someone who's had motion sickness and had them take some Dramamine? to help with that. Those are all first generation antihistamines. Second generation are the common Allegra, Claritin, Zyrtec. Those are the ones that you probably have seen advertised. And so those are here. And you just want to really be familiar with those names. So it comes down here, talks about antihistamine reaction, and it also talks about the fact that there's this anticholinergic action, and that's where you get the drying up secretions, the bronchodilation, those types of things. And you can see that that happens with Phenergan and Dramamine. Benadryl is really the most effective drug out there if you're looking for allergy relief. But as we all know, the downside to Benadryl is being sleepy, that drowsiness. Sometimes it can just knock people out so they fall asleep. Over here on the top right, I wanted to bring this piece to you because it shows in green the antihistamine efficacy, how well it handles antihistamine activity. It also shows you in blue the anticholinergic activity, and then sedation, that drowsiness, is in red. And so if you compare Benadryl here in the middle, it has a fairly good histamine efficacy, not the best. It's actually, of the drugs that they show you, the worst. It has very high anticholinergic activity. It's the highest one on there. But look at sedation. It's way up there. If you compare Benadryl to Allegra and Claritin, on the screen you'll see how Allegra and Claritin are those, excuse me, second generation medications that were really devised for that antihistamine effect while minimizing the drowsiness. Chlorothimetron, Tramadol, and Dimetane, those are also those first generation antihistamines, and you can see their drowsiness is a little bit higher than Allegra and Claritin, but they also tend to be higher, again, in the anticholinergic activity, which means that they can be used for more than just antihistamine activity. All right, H2 blockers, we talked about these, how they're used for GI, and those types of things. Why I have this here is because I wanted you to notice there are 4 H2 blockers to be aware of: Tagamet, Zantac, Axid, and Pepcid. Please make sure you're familiar with those names. All right. So quick quiz questions. What is histamine? Where and how does it act? True or false? The severity of an allergic reaction is dependent on the type of allergen and amount of allergen someone is exposed to. List at least 4 physiological responses to a histamine release. List at least 4 types of allergens that could result in a histamine release. What is histamine intolerance and what could cause it to occur? What do antihistamines do? What are the differences between H1 first generation, H1 second generation, and H2 antihistamines? Give me some names, brand name only, for H1 first generation drugs, H1 second generation drugs, and H2 drugs. Make sure that you can name those or identify those if they're presented in a list. Okay, respiratory drugs. We're going to talk specifically about asthma and COPD, pulmonary hypertension, and cystic fibrosis. And what I want to focus on for all of these is the fact that a lot of times to treat these, they use multi-drug regimens. And those regimens can use things like antibiotics and corticosteroids in addition to the respiratory drugs. Inhalers are the primary way that they use, that they get the drug directly into the lungs, into the respiratory system. So that's why you see for asthma, COPD, you see them using inhalers. They're trying to get that drug directly into the lungs, into the respiratory system, where it's going to act, so it can move forward. It doesn't make sense that if you're trying to get something to the respiratory tract that you get it there through the GI system. So inhalers make sense. Beta agonists are used for acute bronchospasm, exercise-induced asthma, and COPD. These beta agonists are the types that you see most often in the inhalers. There are others, as you'll see as we go forward. And I notice I'm getting close to my 20-minute mark, and I'm afraid I'm not as close to being done as I thought. Sorry about that, but I will try and pick up the pace and stay on track. So here is a visual of asthma. At the top, you see what a healthy bronchiole looks like. Then in the middle, you see what happens when there's irritation and swelling. Maybe there's an allergic reaction that's going on, or maybe it's at the beginning of what's going to be an asthma attack. And you see those bands of muscle are starting to contract and constrict, and you've got mucus production happening. Then once you get to a really we're to the point where the asthma attack is really actually advanced, that's where you have extreme bronchoconstriction there at the bottom, and you've got muscle tightness, which, as you can see, if you look at it, the opening of the bronchiole is fairly wide open in a healthy situation, but it narrows as you go through the inflammation to bronchoconstriction, making it a lot harder to breathe. So this just explains asthma and how that impacts bronchioles, so that you can be thinking about, obviously, how do you want to treat it? You want something that's going to be a bronchodilator. You want it to reverse that constriction activity. And in some cases, you may want a drug that can get rid of that mucus production. And that's where we were talking about those H1 drugs, especially the first generation drugs, where they dry up those secretions, how that could be helpful. So you can see how a multi-drug approach would be ideal. And all I brought this forward for is so that you can see a lot of times they will use bronchodilators. They will also use anti-inflammatory agents, and they will use other things to treat asthma. So again, it's just to emphasize the fact that this is a multi-drug approach, typically with asthma. All right, so COPD. COPD is a term that can be used to describe a range of pulmonary conditions, including chronic bronchitis, emphysema, irreversible or refractory asthma. It's all there under that umbrella. The two main types of COPD are emphysema and chronic bronchitis. And what happens with that? It's different than asthma. Here in the bottom right, there's a visual here. You can see a healthy lung on the left and a lung with COPD on the right. What do you notice? Well, it's talking about how the alveoli lose their elasticity and shape, making it hard to exhale. Air gets trapped in the lungs. The bronchial tubes then become inflamed and narrow, and you end up with thick mucus, causing a chronic cough. That's obviously very different than a healthy lung. So what happens with COPD? Well, because COPD is about 80% of COPD has to do with smoking. Smoking cessation is absolutely critical for these patients. They need to stop. Then they need to look at bronchodilators, and then they have these other additional medications, the LAMA, LABA, all of that. I want to go back a couple slides here really quick. There is a link here. Do you notice that? It is an asthma COPD meds chart. I strongly suggest you take a look at this, just because it will show you exactly what those medications are. So when we talk about this LAMA, LABA type situation, it will show you what those are if you're curious. I'm not going to get into that kind of detail in your quiz, so it's not like you need to know what a LAMA or LABA is, but if you have that interest, that would be a good place to go, that link. All right, so pulmonary hypertension. There are actually 5 different groups or types of pulmonary hypertension, and we're not going to get into the weeds with those because there's just so much. I mean, we could spend a whole week on this and still not quite get to the bottom of it. But I do want to point out that COPD it can be a part of causing pulmonary hypertension. And there are obviously medications that treat it. If you have left heart disease, how you treat that is going to be different than if you're coming at pulmonary hypertension from a COPD standpoint, or something that's drug related or congenital, or something that has to do with a metabolic disorder. These just give you a couple of different types of pulmonary hypertension. And my point of showing you this is, number one, to show you how you have the pulmonary artery and what do you have around it? What do you notice? Mast cells. So you've got some things going on. Normally your pulmonary artery looks like this here on the left, on the far left. But this is what happens with pulmonary hypertension, how it gets constricted. You can see how blood flow then is definitely impacted. But to notice, you've got these other things going on that are influencing that constriction, one of which is mast cells. So just pointing that out. This is another type of pulmonary hypertension. You've got your artery going on here, and you've got different things happening here, and it's acting on that and causing constriction. And although you don't have mast cells, you have other things that are involving the B cells, T cells, neutrophils that involve the immune system. Again, this one here is just to simply show you that once they have the pulmonary arterial hypertension confirmed, there are all sorts of treatments that they can look at to follow through on this. And typically it's more than one. Notice the word combination, excuse me, combination is used here many times. All right, so cystic fibrosis. Cystic fibrosis is a genetic disorder. It's something that someone would inherit through DNA. And what I want to focus on has to do with the lungs. I mean, there's obviously other things that are going on, but I'm focusing here on the lungs since we're focusing on respiratory. So in normal healthy lungs, the airway is lined with a very thin layer of mucus. But in cystic fibrosis, that mucus is very thick, sticky, and it blocks the airway. So that has to be treated. This is an interesting slide. I really liked because it showed the advancement of care for cystic fibrosis patients. Originally, when cystic fibrosis was first identified in 1938, the life expectancy for these patients was less than the age of 5. That's what this age in years is life expectancy. And so in 1938, the life expectancy of these patients was even less than a year. It was a matter of months, maybe. Once they did some more discovering that high salt is in sweat, they developed a sweat chloride test, and they kind of went up from there. They realized that they needed to provide antibiotics. Eventually, they realized that lung transplants would probably be needed. They looked at, they found the gene, the cystic fibrosis gene was identified in 1989. Now they can do a heel prick test for newborns in 2007. And as all of these things have happened and are continuing to be researched to happen, patients with cystic fibrosis are now able to live into their 30s and 40s. And this, I mean, it's just amazing how you can see what has happened for these patients. But getting back to what we were talking about, they absolutely are going to need things that have to do with their lungs on a regular basis to keep that mucus from being too thick and completely obscuring the airway. So quick quiz questions. There's not many. True or false, asthma and COPD are characterized by bronchoconstriction, inflammation, and or obstruction. That is true. Absolutely true. True or false, most drugs are used to treat asthma and COPD are administered by inhalers, so the drug is sent directly to the lungs. What type of drug is used for acute bronchospasm, exercise-induced asthma, and COPD? I'm looking there for beta agonist. Beta agonist. Make sure that you're familiar with that that's the type of drug that's put in the inhalers that people use for acute bronchospasm, exercise-induced asthma, and COPD. And then true or false, multi-drug regimens are rarely used to treat these cystic fibrosis conditions. I'm sorry. Multi-drug regimens are rarely used to treat these respiratory conditions, which include asthma, COPD, pulmonary hypertension, and cystic fibrosis. Sorry about that. I obviously need some more caffeine. All right, so moving on, we're going to talk about autoimmune disease and how immunosuppressives are used with those. So, on the left is a normal immune response, and we talked a little bit about this with allergic reactions. And then on the right is what happens now when your body decides that it's not enough to fight the foreign substance or the invader. It's now time to start, it can't tell the difference between the invader and the body itself, and so it starts attacking the body itself. Immunosuppressives are used to treat autoimmune diseases like myasthenia gravis, rheumatoid arthritis, systemic lupus erythematosus, inflammatory bowel disease, multiple sclerosis, type 1 diabetes mellitus, Guillain-Barré syndrome, chronic inflammatory demyelinating polyneuropathy, psoriasis, Graves' disease, Hashimoto's thyroiditis, and vasculitis. And all of these are where the immune system attacks things it should not and attempts to destroy them. So for some reason, it perceives things in the body not as they are, but as an invader or attacker. And so it starts to destroy them. It uses the immune system to destroy them because it doesn't recognize that they're a normal, healthy part of the body. So often these conditions require a multi-drug regimen. We've been talking about that this morning to successfully treat the disorder. And they often have a strongly negative side effect to them. And you'll see that as we move forward and look at some of these. But notice that when you're talking about autoimmune diseases, you're going to use immunosuppressives, you're going to need multi-drug regimens, and the drugs that you're going to be using are going to have some pretty ugly side effects. All right, so let's talk about methotrexate as an example. This inhibits lymphocyte folate metabolism. It's used in inflammatory bowel disease and rheumatoid arthritis. It can cause nausea, diarrhea, alopecia, which is hair loss. But it can also have hepatotoxicity, meaning that it can be destructive to the liver. And as you go through this list here on the right of major adverse effects, notice that there's renal impairment, and there's infection, and there's heart failure, and there's hypersensitivity, osteoporosis, growth impairment, impaired wound healing, and it also teratogenic. That means it causes cancer. So a lot of these have some ugly side effects, let's just say. All right, so some classifications of immunosuppressants. This just lists that there are different types of immunosuppressants that are used in autoimmune disorders. And then now we're moving on to our last part. This is osteoporosis. So what is osteoporosis and why is it important? How does it affect us? What kind of medications are taken for it? Well, let's talk about that. 10 million Americans live with osteoporosis. 19 billion, that's billion with a B, is about the annual cost of osteoporosis-related fractures that occur every year in the United States. There are 44 million Americans who have low bone mass, and we're going to talk about low bone mass a little bit. Age 30 is when you peak, when you have your best bone mass, when you are at your strongest. Age 50 is when that bone loss increases, especially in women. So what causes osteoporosis in the first place? There are several things, but one of the things I want to emphasize that you need to know is that all osteoporosis stems from low bone density. That's what happens. In a normal healthy bone, you have very high bone density. And I'll show you a picture of that as we go along. But in osteoporosis, which has multiple stages, you go from that high bone density down to a very low bone density. So what happens? How do people end up with osteoporosis? Well, there's genetics. Genetics definitely plays a role. There's gender. Women have smaller, thinner bones, and they tend to have a lower peak bone mass to begin with. Men do get osteoporosis, but it's far more common in women. And for whatever reason, it seems especially common in postmenopausal women who have either Caucasian or Asian ancestry. And then, of course, age. And as we start to slowly lose bone mass at age 40 and more rapidly as time goes on, that also contributes to it. Body frame, and again, we talked a little bit about ethnic background. Those can have a consideration in who gets osteoporosis. Some things that are risk factors that you might be able to control include weight, diet, smoking, heavy drinking, exercise, emotional stress, medications, and chronic diseases. And so I'd really encourage you to go back and read through this and look at those risk factors that you can control just to simply be aware of it and to be knowledgeable about it. So they're just here. And did you notice we're talking about smoking again? We talked about that with respiratory disorders, specifically COPD. Now we're talking about it again for osteoporosis. And then, so that's all of those. There are some medications that can lead to increased bone loss and osteoporosis. Anticoagulants have that. Diuretics can cause some of that. Cancer drugs absolutely have that impact. Some seizure medications may have that side effect. Taking heartburn medications like omeprazole long term can have that impact. Sometimes some antidepressant medications have that as a side effect. So again, it's one of those to just be aware of. And then there are chronic diseases that can accelerate bone loss. And those include hyperparathyroidism, celiac disease, and rheumatoid arthritis. So here's the picture I promised you. On the right-hand side, it shows you bone cross sections displaying the 4 stages of osteoporosis. You can see how on the left you have pretty good bone density. I mean, you have some gaps in there, but it's not nearly what it is on the far right. And you can see as someone progresses with osteoporosis how much easier it is to end up with a fracture because you just don't have the stability in the bone because of the lack of density. And there's information here on the left about that you can go back and read through about how collagen is involved and how we change over our bone density changes over time. And it is true. I mean, there are individuals who have severe osteoporosis and they end up with what's called pathological fractures. They can basically be sitting in a comfortable recliner and barely move and maybe even not move, and all of a sudden they have a fracture because of the bone density issues. All right, so common treatments for osteoporosis. The 2 I want you to focus on are the medication-related ones, the anti-resorptives and the anabolic agents. Those are the 2 we're going to talk about. There are these other options as well, but we're talking about drugs, so that's where we're at. There's no cure for osteoporosis. You can't go back and fix it, but you can treat it and try and increase bone density. So what do you need to know? Medications used to treat osteoporosis are divided into 2 categories. There's the anti-resorptive medications and the bone-forming or anabolic medications. Make sure you're familiar with those terms. And then you've got those listed here. Make sure that you're familiar with the fact that Fosamax, Beniva, Actonel, Reclast, Forticol, Miacalcin, Evista, they are all anti-resorptive medications that are used to treat osteoporosis. And then Forteo is a anabolic or bone-forming medication. So just make sure you're familiar with that. Now, the unfortunate part about these medications that are used to treat osteoporosis is that they can have some rather challenging side effects. For instance, if you end up taking Evista, which is a selective estrogen receptor modulator, that is known to worsen hot flashes and cause blood clots. So, for instance, there are those types of things. Forteo is a parathyroid hormone, and there's still some concerns about its long-term safety. It's also very expensive. It can be up to $7,000 a year. Things like Fosamax, Beniva, Actonel, Reclast, they're called bisphosphonates, and they've been linked to lesions in the stomach, esophagus, abnormal heart rhythm, and muscle pain. So just again, be aware of side effects. So last set of quick quiz questions. What are immunosuppressives and what do they do? List at least 6 autoimmune disorders that are treated with immunosuppressives. True or false, autoimmune disorders often require a multi-drug regimen, not regiment, sorry, regimen. I'll get that fixed. For successful treatment, true or false, immunosuppressives rarely have strong negative side effects. What are the causes of osteoporosis? What are some risk factors for osteoporosis? True or false, osteoporosis has multiple stages which are characterized by progressively lower and lower bone density. What are the 2 types of drugs used to treat osteoporosis? And list at least 4 brand names of drugs used to treat osteoporosis. True or false, most drugs used to treat osteoporosis have mild or no side effects. All right, have a fabulous week. I will be back next week. It will actually be our last week that where we'll finish off our book. We will be on chapters 42, 43, and 46. Then we're going to move on in week 15 and talk about drug identification. And then in week 16, we'll be finishing up with off-label drug use and some miscellaneous other topics that have to do with pharmacology. And then we will be almost done. So take care. Have a wonderful week. Hopefully we'll have great weather. And I will be back to talk to you next week and we'll finish off our book. Take care.